Okay, I did my presentation on traumatic brain injury and attention. It's a result of abrupt external forces acting on the skull and brain. It's a non-degenerative acquired brain injury, which means it happens after birth, and it's the leading cause of neurologic disability in people under age 50. There's two types. There's a penetrating head injury, which we'll all remember Phineas Gage and the tamping iron that went through his skull and his brain, and those tend to be more focal in nature. There's also closed head injuries where the skull and the meninges remain intact. These are most likely the result of a fall or an accident, and they tend to be more diffuse in nature. Around 1.7 million people in the US suffer from a TBI every year. It tends to be older adolescents, older adults, and males more so because of sports and war injuries. Approximately 5.3 million people in the US live with a long-term disability as a result of a TBI. And some symptoms appear immediately and others may develop over time, such as post-traumatic stress disorder, depression, anxiety, and sleep problems. And a TBI predisposes a person to another brain injury before they may have even recovered from the first one. Approximately 75% of TBIs that occur each year are mild in nature, such as concussions. You can see from the graph that falls and car accidents are the leading causes. They're rated on a scale of mild to severe, and this has to do with the amount of time a person is unconscious and their level of memory loss. TBI can also cause epilepsy and put a person at an increased risk for Alzheimer's, Parkinson's, and other brain disorders that become more prevalent with age. We'll remember Michael J. Fox and how he was in a car accident and suffered a head injury, which might have brought forth his Parkinson's disease at such an early age. For those hospitalized with TBI, 43% have a related injury or disability 1 year after the injury. Now, depending on where the injury occurs in the brain, you're going to see different deficits, and we've talked about this in class. There's going to be different deficits on the left side versus the right side, and I'll let you guys look this over since we've talked about it in class. The SLP is going to be looking at language deficits affecting like comprehension, verbal expression, pragmatics, reading and writing, motor speech deficits such as apraxia and dysarthria, voice and swallowing deficits, and cognitive deficits such as attention, perception, memory, and executive function. And the book talks about how communication deficits of TBI patients are often a secondary consequence of the problems that they have with their cognitive processes. ASHA has a really nice TBI evidence map, which is good for SLPs to understand their role in assessment, treatment, and service delivery. In regards to this type of injury, you just click on the little boxes and it gives you lots of good information. Attention is a universal consequence of TBI, much like word finding is in aphasia. People with TBI have a reduced attention span. They get distracted easily. They have difficulty with selective and sustained attention and deficits in shifting attention between tasks. And what this means is in their everyday life, it's going to be difficult for them to maintain attention in the face of competing stimuli. They're going to be slow to shift attention from one stimulus to another. Conversational interactions where speakers and topics change quickly are going to be hard, as well as conversation and noise. Divided attention is difficult, and it can be hard for them to separate what is important from what is not in both spoken and printed material. It's important to assess for alertness, attention, memory, visual perceptual abilities, language, communication, reason, and problem solving. These are 3 tests the book recommends to assess for attention. The test of everyday attention, also known as the T, is good for estimating their attention deficits on tasks in everyday life. And it's important to wait to assess a TBI patient until they've had a little time to recover, until they get past that initial state of confusion and agitation and, are able to focus. I focused on attention process training, which is one of the most well-known and widely used programs for treating attention. It's based on Solberg and Mader's 5-component model of attention. They break it down into focus, sustained, selective, alternating, and divided attention, and it's treated sequentially in that order. They believe focused, sustained, and selective attention are necessary before treating alternating and divided attention. And this type of training increases the complexity of targets throughout the course of the training. It uses intense repetition of exercises to help reestablish neural connections, and the trainees progress at their own pace through the program. APT training starts with sustained attention. Visual cancellation tasks are used. In Chapter 11 in our book, it shows some good examples of that. It's usually a pen and paper task where they're crossing out visual targets. There's also auditory vigilance tasks where they push a button when they hear a specific target, and serial calculation tasks that have to do with counting and adding and subtracting. Selective attention is treated next, and it uses much of the same tasks as was used in sustained attention, except added distractions are put in place, which makes it more difficult. Then you move on to alternating attention, where the examiner is going to say switch. So first they're going to be adding and then subtracting. They're going to be working with evens and then switch to odds. Then there's divided attention, where they're paying attention to two aspects of a single task, like letter cancellation, while also saying yes every time they hear the examiner say the number 5 in a random string of numbers, or card sorting tasks, where they're selecting cards based on 2 criteria at the same time. The first study I looked at was an attempt to ameliorate the difficulty faced by many of TBI patients of paying attention to conversation in the presence of background noise. There are a TBI group and a control group used. They used a dichotic listening procedure where participants listened to a narrative story in one ear and a second distracting story was presented in the second ear. The decibel level was manipulated in the ear with a distracting story, but it was held constant in the ear for the story they were attending to. Multiple choice questions were then asked regarding the story's content. They modified the APT training by systematically increasing the background noise across the course of the training to simulate like noise levels in the real environment. Participants in one group had their training level adjusted in difficulty based off of their performance. The other group didn't have this performance adaptation, but they were exposed to the noise level for the same amount of time as the adaptive group. The results showed that for the TBI and control group, initial decline in their performance with the background noise, while the control group was able to adapt and their performance increased and exceeded baseline levels. The TBI group's performance just kept steadily declining with that competing speech noise. But after the APT training, TBI groups showed significant improvement in performance and noise, and it happened in both the adaptive and non-adaptive groups. The next study I looked at was a computer-based treatment for attention. It used APT3, which is a computer-based version of what we've been talking about, and it also used Lumosity brain games. The researchers selected 5 attention-oriented Lumosity games for the participants, and the participants engaged in both versions of this computer training. Participants progressed at their own speed through multiple levels. They used the T to check for generalization, and they were also probed to check their performance. The results showed that all participants had statistically significant progress in reaching new levels of difficulty on attention tasks with both programs, and probes showed generalization of improved attention happened primarily during the first intervention period, regardless of what program they were using. But the T results were too inconsistent to claim generalization of improved attention. The results call into question the claims that this type of computer-based cognitive training is helpful to all people who engage in it. The results also demonstrate difficulty with generalizing this type of improvement over to everyday life tasks. I next looked at a study on the effectiveness of APT training. It was a small study that used 2 patients with severe TBI who were 1 year post-trauma, and that was to help control for spontaneous recovery. APT therapy was administered to both patients The results showed that they improved in some but not all tests of attention, most notably in selective and divided attention. Results from the T did indicate generalization of training, and larger studies would help to verify this. It demonstrated the importance of looking at individual performance during the training to help understand the differences and patterns of attentional deficits. The results show for attention process training that they're mixed. It tends to show improvement on attention tasks, but people argue that this is due to practice effects, and generalization to everyday life situations isn't as strong. Other reviews show that it might be most effective during the post-acute period or with people with mild TBI, and research does show improvement in attention due to APT training, but more research is needed to establish its efficacy. And this is a video of a woman who suffered from TBI and some of the problems she faces now in her everyday life as a result. And that's, the end.